Thank you for the kind invitation to Manos and Manos. And well, the topic infection, I think, cannot be covered in 10 to 15 minutes because I will just give you, I will say, highlights on how to treat or how to at least get an impression of an affected shoulder arthroplasty. So these are my disclosures. So why do we talk about infected shoulder? And if you look at this paper, we see that the mortality rate in patients with infected shoulder arthroplasties is much higher than in patients with aseptic loosening. So the fact of infection is really a matter to our patients. So we have existing algorithms in the knee and in the hip, and they are really well described and well known, as you can see here in this. So these are from the Pro Implant Foundation, which all hip and knee surgeons use, I would say, in Germany or at least in Europe and in the United States. So the question is, can we compare a shoulder to a knee or to a hip? And I would say, no, we cannot. But why is that? So if you go to PubMed and you put in the terms periprosthetic and infection and the hip, the knee, and the shoulder, you see the difference. Okay, so we know a lot more about hip and knee infections than we know about the shoulder infection, at least for the last 20 years of research. And why is this? Because we have a totally different spectrum of organism in the shoulder than we have in the knee and the hip. As you look here on this one, most of the time in this study, it's Propionibacterium acnes and Staphylococcus epidermis. So these are the most found organisms in the shoulder, which are not equal to hip or knee infections. And also in this one you see Propionibacterium acnes is the leading cause of shoulder infection. So the other problem we have with these organisms, especially for P. acne, is the time till the diagnosis. And as you can see here, the mean time between implantation and diagnosis is 34 months, which I will shortly show you a difficult problem in these terms because we know we have the acute infection and we have the chronic infection. And with a mean time of 34 months, in this, we all put our shoulders into this chronic infection. So most of them are chronic infected and are not within the first 3 weeks of implantation. So the next question would be how to diagnose the infection. So we have different options for that. We have blood markers, we have synovial analysis, and we have, of course, the microbiology. So what about the biomarkers? The classic infection parameter we use in our clinics is the CRP. And if you look at the study out there, that the CRP is not a very, very good predictor of infection because it can rise with and without infection. So the infection parameter, or at least the classic infection parameter, sensitivity is not very good, and also the specificity is not very good. What about the D-dimer? So this is a fibrinolysis parameter. We know that this might be an option in patients where we suspect infection. We saw that the level of D-dimer is significantly higher than in patients without periprosthetic joints infection, but we also know that the D-dimer levels are also higher in different pathologies. So if we look at the D-dimer, the fibrinolysis parameter, the sensitivity is okay, and the specificity is, well, it's okay, but it's not the best. So what about the cell analysis, which is proven that we know in knee and hip infection or in surgery? So the question would be the accuracy of the synovial leukocyte and polynuclear cell count in patients with infected prosthesis. And the problem, as you can see here from this study, is they took 39 aspirations from these patients and they had to exclude 20 of these punctures, and only a few can be used for analysis. So the problem is to get any cells of this infection. So what about the synovial fluid white blood cell count? there is a significant threshold. So we can see that the cell count in these infected shoulders is much higher than in normal shoulders, and there's a threshold about 2,800 leukocytes per cubic millimeters, which show a good sensitivity and also a specificity. So once you reach these levels, you can be surely high that it is an infected joint. What about the joint aspiration? So when it comes to microbiology, so we want to set a culture to see what organism we're talking about. And this is a study from Carl Wieser, and also they did the aspirations, and also can see here, they had direct liquid only in 60 cases, and after saline solution injection, they got another 43 cases. So where 3 cases remained unsuccessful. And from all these cases, 24 shoulders were infected, but only 10 of 24 yield as pathogens in the aspirate. So you see it's very hard and difficult to find or determine the organism which has affected the shoulder. So the other one that George already mentioned is the arthroscopic biopsy, which is a possible addition to define or clarify a periprosthetic joint infection. From this study, you can see they took samples from 22 patients, and only 2 positive samples were grown with the same microbiological growth. But they summarized that they have a high sensitivity and a high specificity once they found the organism. So this is a possible addition. The sensitivity is okay, and the specificity is very good. So the last one will be the open biopsy, which I will not further highlight in this presentation, but because it will take too long to talk about that. So how to treat the infected shoulder. So basically we have this line. This line marks the biofilm production on the implant. So within the first 3 weeks, which we call the acute infection, we want to keep the implant. Once it gets to a chronic, we have to change the implant because of the biofilm production. So these are all the options we have in these cases, and I just want to highlight a few of them, which would be the implant retention and the change of implant. So when do we do implant retention? There's a technique called the DIA, which is the diagnostic debridement and implant retention. And as you can see from this study here, which is highlighted in the green line, the postoperative complication with this technique is very, very high. 38% of these cases had reinfection and complication and had to be reoperated. Why is this? Because as mentioned before, most of the time of the infection are not the acute ones, so we don't see a lot of staph aureus in the infection, but we see all these germs like epidermis derms and P. acne. So when to do this technique, if you have infection suspected, you have elevated CRP, you have positive joint aspiration, you have joint replacement which is less than 6 weeks, you have mild symptoms, and the signs of infection less than 21 days. Yes, you can go for arthroscopic debridement and implant retention, but you need to have a low virulent bacteria, and you need to know the bacteria. So in most of the cases, this therapeutic approach is not very good because we don't see them. So when we have to change the implant, that's two-stage surgical revision is the standard, or was a standard of care to treat these patients. Nowadays, we have different possibilities for these two-stage revisions. We have different shaping tools to make it much easier once we get in for the second stage. It's shown in this one here, and then we have a final solution, hopefully. So normally the medium interval between stage 1 and stage 2 is about 4 months to go in for the second time. So now we look at the outcomes in treatments of these periprosthetic joint infection. And here is a very interesting highlighting the different types of approaches. And as you can see on the right side, the two-stage revision showed the best outcomes in times of failure and successful rate. But what about two-stage surgical revision? Is it always the best? So sometimes we are comparing apple with pears. So if you can see here, in the patient group, the reimplantation rate and the non-reimplantation rate differs from age. So you see the patients which are not reimplanted are much older, and also the CCI, which is the Carlson Comorbidity Index, is much different to those patients who got a reimplantation. So we cannot always talk about two-stage strategy. We also have to admit or take into account the different comorbidity problems of these patients. So one-stage revision, is there a possible alternative to this two-stage revision? Well, there is the one-stage revision, but as you can see, the success rate or the failure rate is not so good than the two-stage revisions. And it's always depending on the absence or the presence of positive cultures in these patients. Also, here comparing one-stage to two-stage, the one-stage revision rate means the rate of reinfection is much lower compared to this two-stage. This is taking into account that the one-stage revision is most of the time is a very well-known organism and is easier to treat. If you look at the outcomes, at the clinical outcomes, there's no difference in one-stage or two-stage revision as you look at the p-values here from the standpoint of range of motion. So the take-home message for the infected shoulder arthroplasty is depending on the duration of symptoms. If it's less than 3 weeks, you can call it an acute infection, but then you have to have a stable implant. You need to know the viral pathogen, and you have to have a favorable residuogram. If you don't have it, it's a chronic infection, and then you can see and follow all these algorithm points how to treat your infected implant, hopefully for the best of your patient. And I also invite you to come and visit Munich next year for the ISAKOS Congress 2025 in Munich. Thank you.